Good afternoon. My name is Jane Stanville. I am a Senior Policy Analyst at the Office of National Drug Control Policy. I'd like to start by thanking everyone for registering for today's webinar to learn about how collaborations between local nonprofit hospitals and community coalitions can reduce local substance use. Special thanks go to our presenters, who are all respected experts and represent the fields of research, community health improvement. I will introduce them in just a few moments. But first, a few words from our AT&T operator before we get started.
All right, thank you very much. I would like to remind participants that this webinar is being recorded. There will be approximately 10 minutes for Q&A after the presentations have concluded. We will start the Q&A with a few of the questions submitted by attendees when they registered, and if time permits, we'll open the lines for questions from our audience members. Please note that all lines but the speaker's lines will be muted until further notice. To adjust your presentation view, you can simultaneously click the Control and the minus key on your keyboard. And with that, I'll now turn it back to Jane Stanville.
Thank you. As substance use is becoming an area of greater concern in many communities, we have heard increasing interest in learning more about effective approaches that can reduce use and help communities. Today you will hear that there are a wide range of evidence-based approaches and models for hospitals and community coalition collaborations that can reduce substance use. Before we proceed with our panelist presentations, it is now my privilege to introduce Mary Lou Leary, ONDCP's Deputy Director for the Office of Policy, Research, and Budget. Deputy Director Leary came to ONDCP from the Department of Justice, where she served as the Principal Deputy Assistant Attorney General in the Office of Justice Programs. She has 30 years of experience in the field of criminal justice and victim advocacy and is a staunch supporter of prevention. Deputy Director Leary, I turn it over to you.
Thank you so much, Jane. And I want to also thank our presenters today for not only for the time and thought that went into their presentations today, but for the work they do to improve our understanding of effective practices to improve the health of our communities. We're lucky to have Dr. Bethany Deeds from NIDA and Sue Thao from the Community Anti-Drug Coalitions of America and Leslie Aldrich from the Center of Community Health Improvement at Mass General Hospital. And thanks to each of you for registering and participating in the webinar today. The provisions of the Affordable Care Act and community benefit are still relatively new, and we're exploring ways to foster collaborations between nonprofit hospitals and community coalitions to improve the health of our communities, especially in the area of substance use. Today, you will hear about evidence-based prevention that can be implemented at the local level, models of hospital and coalition collaboration, and data on the impact of evidence-based policies and programs that can address the substance use challenges identified in community health needs assessments. We all know that there isn't any one-size-fits-all solution, but we do know that when communities come together, they are able to identify viable solutions. And that's one of the reasons why I think today's presentation is so important. Just for a moment, I want to give you a brief overview of the Office of National Drug Control Policy. We are an office in the White House, and we advise the President on effective drug policy for the nation. And we produce a strategy, the National Drug Strategy, to provide that guidance. And it sets forth overarching goals to address the public health and the public safety challenges of the 21st century. And basically, the strategy is guided by three concepts. One, addiction is a brain disease, and like any disease, it can be prevented and it can be treated. Two, people with substance use disorders can and do recover. And three, innovative new criminal justice reforms can help stop the revolving door of drug use, crime, incarceration, and rearrest. Next slide. One of ONDCP's concerns is that the overall burden of disease due to substance use disorders. As you can see from these data from the National Survey of Drug Use and Health, we've seen an increase in illicit drug use among people 12 years of age and older. That 2014 estimate is significantly higher compared to each year from 2002 to 2013, and that's a cause of concern for all of us. Next slide. We're also concerned about the youth use of drugs. You can see from this slide that the rate of illicit drug use among school-age children increases dramatically between ages 12 and 18. At age 12, 2.6% are current or past month users. At 14, the rate has more than doubled at 5.8%. 2 years later, at age 16, the rate has more than doubled again. And by age 18, more than 1 in 5, that's over 20%, were current drug users. The overall drug use rates are highest for ages 18 to 23, with at least 1 in 5 reporting current use of an illicit drug. Next slide. This slide captures a concerning trend. Nationwide drug poisoning deaths, as you can see, have steadily increased. Deaths from motor vehicle crashes, on the other hand, have been declining. Since 2009, drug poisoning deaths have exceeded motor vehicle crashes and are now the leading cause of death from injury. And while there's a lot more data that we could discuss, I will stop there and look forward to hearing our presenters who can talk about how we can work to prevent substance use and to reverse these trends that we see in the slides. Next slide.
Deputy Director Leary, thank you for those opening remarks. I will now introduce today's presenters. Dr. Bethany Deeds is our first presenter. She is Chief of the Prevention Research Branch in the Division of Epidemiology, Services, and Prevention Research at the National Institute on Drug Abuse. She will provide an overview of evidence-based prevention approaches. Our second presenter is Ms. Sue Thaw. She is a public policy consultant for the Community Anti-Drug Coalitions of America and will speak to models of successful hospital and coalition collaborations and the community impact of those collaborations. Our final speaker is Ms. Leslie Aldrich, Associate Director, Center for Community Health Improvement at Massachusetts General Hospital. She will speak to a unique hospital and community collaboration that addressed issues identified in their community health assessment, how they use the assessment data to inform the hospital's strategic plan regarding substance use, and the positive impact they have seen. Before we begin, I'd like to remind participants that questions will be addressed during the Q&A session that will take place after all the presentations have been completed. I will now turn it over to Dr. Bethany Deeds. Bethany?
Hi, it's my pleasure to speak with you this afternoon. I wanted to share with you a little bit about the importance of using evidence-based prevention to address the needs of communities. Next slide, please. This short presentation is aimed to give you an overview of some of the prevention evidence and tools that are at your disposal to support your important community benefit activities while you partner with coalitions to address the substance use needs of your communities. I'm going to start with an overview of the prevention research at NIDA, provide a summary of substance use prevention evidence, and describe some of the principles of prevention, provide examples of interventions that are available to you, and then I want to focus on two systems models, Prosper and Communities That Care, to illustrate the power of collaborations. I'll wrap up by sharing some cost-benefit information and additional resources. So let's start with the prevention research topic. Next slide. How does an evidence base evolve? NIDA is one of several institutes at NIH. We strategically support and conduct research across a broad range of disciplines and ensure the rapid and effective dissemination and use of the results of the research significantly improve prevention and treatment and inform policy as it relates to drug abuse and addiction. So in other words, we fuel the creation of the evidence. For prevention research, we support a theory-driven program of basic clinical and services research across the lifespan. So to prevent and delay the initiation of drug use, prevent and delay the progression of drug use to abuse, and prevent drug-related HIV acquisition, transmission, and progression. So our focus is preventing use and abuse before dependence and treatment. Next slide. In public health research, you might hear the terms primary, secondary, or tertiary used to map out a range of interventions. We use risk level terms from the Institute of Medicine report to describe how our research is being conducted. Universal interventions target general populations, like all students in a school. The term selective refers to interventions focused on groups of individuals at risk due to some characteristic of the group. An example would be poor school achievers. Indicated denotes individuals who have begun using drugs but are not diagnosed with a disorder, so the goal here would be to prevent progression to abuse or dependence. And lastly, tiered interventions refer to one where two or more levels of risk are addressed. Next slide. We foster research that targets critical periods across the developmental lifespan and to reduce risk factors and enhance protective factors. This is based on a psychosocial behavioral approach. So our corresponding tagline would be whole person, in context, across the lifespan. This chart really depicts how interventions can be designed to target risk and protective factors in the individual, family, peer, school, and community domains. The ultimate goal then is to enhance protective factors while reducing the risk factors. Next slide. So how does this work? The key is that interventions target modifiable risk and protective factors. This is how we conceptualize interventions working. The modifiable risk factors are those factors that are hypothesized to be open to change, such as the development of social skills. Change can occur either naturally, through environmental exposure, or through planned strategies presented in interventions. Moderators are the fixed or virtually unchangeable factors like age or gender. And these moderators, though unchangeable, they do affect the modifiable risk factors, so they have to be accounted for in the research. Intervention strategies are these activities and information, and they're designed to influence these modifiable risk factors through developing skills, abilities, and competencies. Moreover, the interventions are typically targeted at points of vulnerability or transition. And it's at these points that change is most likely to be naturally occurring. So for instance, the transition between elementary school to middle school or middle school to high school. Next slide. After sharing how prevention research evolves and the thoughtfulness that is taken into account when these interventions are developed and tested, I wanted to move on to share some prevention principles that have accumulated and some examples of interventions that make up this evidence base. Next slide. I wanted to start off by sharing some examples of established substance use prevention principles from early childhood. So early childhood here is defined as the prenatal period in infancy through transition to elementary school, so around the age of 8. Intervening early in childhood can alter the life course trajectory in a positive direction. Intervening early in childhood can both increase protective factors and reduce risk factors. Intervening early in childhood can have effects on a wide array of behaviors, even behaviors not specifically targeted by the intervention. Next slide. These principles are synthesized from a new resource that NIDA launched in March of 2016 called Principles of Substance Abuse Prevention for Early Childhood. The URL for this online guide is located at the bottom left-hand corner of this slide. A growing body of research indicates that by providing a stable home, adequate nutrition, physical and cognitive stimulation, warm, supportive parenting, and good classroom management in the early years of a child's life can lead the child to develop strong self-regulation, in other words, good emotional and behavioral control, and other qualities that protect against a multitude of risks and increases the likelihood of positive developmental outcomes. Positive effects of these interventions include delayed initiation and decreased use of drugs when the child reaches adolescence. Next slide. These next slides show NIDA-supported research over the past 3 decades, which has resulted in the development of a range of early intervention substance abuse prevention programs that span the prenatal period, infancy and toddlerhood, preschool, next slide, and the transition to elementary school. The programs described here are arranged by developmental period. Within each age range, programs are presented according to the level of prevention: universal, selective, tiered. Next slide. The web-based resource is an easy-to-navigate with printer-friendly chapters viewable on the desktop, phone, tablet, as well as brief summaries, findings, and program contact information for all of these interventions. Next slide. The next two slides depict some additional prevention principles that have emerged over the past 30 years of research for children and adolescents. So the use of universal prevention interventions and community approaches are important so no one is singled out or stigmatized, and that universal interventions also can have impacts on even the highest risk youth. Crossover effects are important too. Prevention interventions have an effect on multiple risk behaviors, including those not targeted and not a focus of the intervention. So an example of this would be an intervention targeting reductions in substance use and concurrently getting reductions in HIV and sexual risk behaviors. So we commonly term this as crossover effects. And then lastly, prevention interventions implemented during earlier developmental periods have effects during adolescence and later developmental stages, and we call this long-term effects. Next slide. These principles, along with several others, are synthesized from another resource that NIDA produced called Preventing Drug Use Among Children and Adolescents. The second edition was published in 2003, and its URL is located in the bottom left-hand corner of this slide as well. Next slide. The next three slides present examples of research-based programs that use a wide variety of strategies that have proven effective in preventing drug abuse. The interventions were tested in family, school, and community settings. Next slide. The examples are again presented by their risk level: universal, selective, indicated, or tiered, and for whom they're designed: elementary, middle, high school audience. Next slide. The URL I shared previously will have this guide, and it provides more information on research-based prevention with questions and answers on risk and protective factors, community planning and implementation, a fuller list of prevention principles, and brief summaries, findings, and program contact information for the interventions. Next slide. So it's one thing to talk about research's effects under controlled conditions. But what happens to evidence-based interventions under real-world conditions? Do they still produce positive outcomes? The answer is absolutely, and I'm going to share two examples. Next slide. I wanted to highlight two long-standing programs of research directed towards moving evidence-based interventions and systems into real-world settings and building infrastructure and sustainability at state and local levels. The two examples I'm going to share are Communities That Care and Prosper, promoting school-community university partnerships to enhance resiliency. The take-home message is that these systems, models demonstrate community and population-level impacts. Next slide. The Communities That Care model guides communities through a proven 5-phase change process. They use prevention science as its base, and Communities That Care promotes healthy youth development, improves youth outcomes, and reduces problem behaviors. The model encourages communities to demonstrate readiness to adopt evidence-based interventions, to work together in doing this through the creation of a collaborative community process, through which they develop a community-specific profile of risk and protective factors and a plan for addressing them. They follow up by implementing and evaluating the selected programs to address these risks from a menu of evidence-based interventions. Next slide. This slide depicts the 5 phases of the Community That Cares model that I just mentioned. Get started, get organized, develop a community profile, develop a community action plan, and implement and evaluate the plan. Next slide. I also wanted to share a graphic example of how community data can be used to identify areas of elevated risk, which could inform the selection and implementation of an evidence-based prevention intervention and address the targeted risk factors. So this illustration shows neighborhoods. On this image, it has higher mountain-type peaks and orange-brown colors. This shows that more risk factors are present in these particular communities. Next slide. NIDA funded a community-based a randomized trial of communities that care. And this slide shows a finding from it. Data were from a longitudinal panel of public school students in these 24 communities and were followed from grade 5 through grade 12. And so by the spring of the 12th grade, students in the CTC communities were more likely than students in the control communities to have abstained from any drug use, drinking of alcohol, smoking of cigarettes, and engaging in delinquency, and also were less likely to have ever committed a violent act. So the take-home message is that using the Communities That Care system continued to prevent the initiation of adolescent problem behaviors through the 12th grade, 8 years after the implementation of CTC, and 3 years after study-provided resources had ended. Next slide. This is the URL for the Community That Cares website. It shares information on how it works, the research behind it, and the results, and how to get started. They also have videos where you can preview the training and learn more about the process. It's very user-friendly and also has contact information for the Social Development Research Group at the University of Washington. Next slide. A second very large implementation model that NIDA supports is the testing of the PROSPER project. PROSPER is a partnership model too. It's between the University Extension Program specialists, researchers, and county-level extension prevention coordinators and local community teams. These teams assist in a community planning process. It first engages the families in schools, then provides family and school-based programming targeting middle school youth, which is a period of high vulnerability. This model also offers a menu of family and school programs for communities to select from as well. Next slide. This slide depicts PROSPER's impact on illicit substance use, the dark blue line, compared to the control group, the light blue. Take-home message is that youth participating in programs implemented through this PROSPER delivery system scored significantly lower on a number of negative behavioral outcomes, including drunkenness, cigarette use, marijuana use, the use of other illicit substances, shown here, and conduct problem behaviors, up to 6.5 years past the baseline. And in many cases, higher risk youth benefited even more. Next slide. This second PROSPER finding demonstrates a beneficial effect on adolescent social networks from a universal intervention to prevent substance use. In school districts randomly assigned to this PROSPER intervention, students' friendship networks changed in a way that reduces diffusion of problem behaviors relative to the control districts. In this visualization, the black dots represent an adolescent who uses substances, while the white dots show an adolescent who does not use. Peer social network analyses showed that PROSPER reduces negative peer influences. You can see this effect by comparing the two images. And seeing the black dots are the adolescents using substances shifting to the outside or a less centric role in the network, thereby shifting the peer influence towards non-users. Next slide. This is the website and URL for PROSPER. It shares information about the PROSPER model, how it works, its proven results, and the national network team, and how to start a PROSPER partnership in your state. Next slide. Lastly, I wanted to end on the topic of cost effectiveness. Next slide. Next slide. Sorry, we were one off. When I mentioned examples of prevention principles earlier in this presentation, I saved one for the end to emphasize, and that is that prevention interventions and systems can significantly reduce health and broader social costs. Next slide. Research has shown that preventing drug abuse and other problem behaviors can produce benefits for communities that outweigh the monetary costs. Implementing research-based substance abuse prevention efforts can yield many positive outcomes, such as decreased need for treatment of substance addiction and dependence, reduced delinquency and crime, and better health outcomes. This slide illustrates this benefit by sharing some data on prevention programs that were included throughout this presentation, and this data come from an analysis conducted by the Washington State Institute for Public Policy. Next slide. Before I wrap up, I wanted to leave you with some additional resources too. Next slide. These next slides have links on them to resources that you might find useful in your work. I placed them here so that you have easy access to the information after the presentation. This slide summarizes the guides and resources that NIDA has produced. Next slide. This slide shows the NIH Reporter System. It's an online searchable database of funded NIH research. You can use it to query the system to find prevention researchers in your state or other areas that interest you. Next slide. These next two slides share other resources as well. For example, SAMHSA's National Registry of Evidence-Based Programs and Practices, NREP, the searchable online registry of more than 350 substance use and mental health interventions. Next slide. And Washington State Institute for Public Policy has wonderful information on cost-benefit results, some of which I've included in this presentation. Next slide. In closing, this is the prevention research team at NIDA. I especially wanted to thank Belinda Sims and several colleagues that have since left NIDA, like Liz Robertson and Eve Ryder. It was under their stewardship that these guides I mentioned in this presentation came to fruition. Next slide. If you have any questions that come to mind after this presentation, please don't hesitate to contact me at my email address listed here. Next slide. And lastly, I wanted to end on a more personal note. When I started my career, I worked in a teen clinic in Baltimore City Hospital, coordinating prevention activities. And then later, after that, I earned my PhD and I became a coalition director. I truly understand what it feels like to occupy a space in between competing interests, between time commitments, between different missions, and the list goes on, and oh my, how awkward it can feel to start something new or fill a gap area in that in-between space. But I also learned from my time in both of those roles about the power of people. I saw so many examples of how one person made all the difference in a collaborative group effort. One person changed the dynamics of agencies working together, and one person brought someone to the table that was needed and could never have been reached before. I wish you well on your prospective journeys in your communities and wish that your presence makes all the difference. Thanks for your time.
Bethany, thank you for that very informative presentation and the inspiring words from your experience. I now will turn it over to another inspiring person, Sue Thaw, who will talk about how community coalitions and hospitals can work together to reduce local substance use. Sue?
Oh, well, thank you so much, Jane. Next slide. Thank you. There's actually a conceptual model for community coalition-based substance use prevention, which Yuri Bronfenbrenner from Cornell developed in the late 1970s, which is the social ecological model. Next slide. And the whole purpose of this model is to show that individuals are actually embedded or nested in much broader contexts that can play very critical roles in their health and well-being. So the web of connections that surround individuals, microsystems like family, peer groups, schools, organizations, localities with their policies, practices, laws, ordinance, enforcement, all of those actually are very important interventions that affect individuals. So we have to make sure when we do our prevention that we're aware of all of the models, all of the levels of this model and how they actually can work together to get amazing outcomes to help individuals stay healthy and substance-free. Next slide, please. We have a definition at CADGA of a coalition. Everybody now is working in coalitions. It's like the new thing. So ours definition is a formal arrangement for cooperation and collaboration between multiple groups or sectors of a community in which each group retains its identity. So the hospital working with the coalition remains the hospital, doing what hospitals do, but they bring all of their expertise, their personnel, their talents, and their treasures to the table to actually enhance what the coalition is able to do. And so, next slide, please. The basic concept behind the coalitions that we're talking about is that they bring all of the community sectors together to develop and carry out data-driven, evidence-based strategies to achieve the types of population-level reductions that were just explained in the models that my preceding speaker talked about, so that in fact we can reduce underage drinking, tobacco use, illicit drug use, prescription drug and over-the-counter use and misuse at a population level by everybody coming together in a community, looking at their data, and next slide, working across everybody in a community. So basically we've identified 12 sectors for the Drug-Free Communities program, but this is something that's both bottom up, top down, so you have youth and parents who are basically residents of the community, business, media, schools, youth-serving organizations, law enforcement, the faith community, civic and volunteer leaders, healthcare professionals, and hospitals, state and local governments, and other organizations. So as you can see, these are the parts of the social ecological model that actually would have an effect on individuals when they all work together. Next slide. All good prevention is based on planning processes. You saw one in the preceding presentation. The one that we use is called the Strategic Prevention Framework, and basically everything is based on understanding local data so that you know not only the issues and problems in your community, but also the social capital and assets in your community that can help you to address whatever your issues are. Capacity, building the multi-sector capacity to actually do all of the work that's needed from assessment through evaluation in this model. Planning, you use all of your data and your social capital and all of the information about your community to do basically a strategic plan based on your assessment, as well as a logic model that says not just what are the problems in this community, but how do they show up in this community? So you might know underage drinking is a problem in your community, but how are kids accessing? Where is the alcohol coming from? So that you can target your interventions in your implementation phase, which is the next phase of this model, to the exact conditions in your community which are part of producing the problem behaviors. And then everything is based on evaluating how you're doing, looking at data from a baseline, seeing if you're actually making a difference, meeting the benchmarks that you've set for yourself, so that if you are, you can celebrate. And if you're not, you need to go back and recalibrate your model so that you can make sure that you actually are achieving population-level reductions in substance use and abuse. Next slide. So community coalitions can drive community-level change. And what they seek to do is impact a specific, defined part of the community. It can be a neighborhood. It could be the whole community. Engage all of the 12 sectors that I went through in a previous slide and members of the entire community. Address conditions and settings within the defined community so that, in fact, you get to the outer regions of that social ecological model. Promote comprehensive strategies. This is sort of multiple strategies across multiple sectors of the community. So everybody's doing their part to implement the comprehensive strategic plan. And then the goal is to achieve positive population-level reductions in substance use and abuse rates throughout the entire community. Next slide. So there really are differences between coalitions and prevention programs, and I just want to take a minute to go through these. The scale of a coalition basically is looking across the whole community at community-level indicators that would apply to everybody living in the community. Programs usually measure change in individuals who have been directly impacted by a specific intervention. Again, coalitions address multiple causes of a problem. As I explained with underage drinking, access, availability, social norms, they don't just look at one single strategy for dealing with a problem, such as parenting classes and peer mentoring, which are all very important and are parts of these multiple strategies across multiple sectors. But in fact, in a coalition, everybody is doing their part in implementing the strategic plan. And as far as who's doing it, coalition activities are very diffused. They're done by all of the sectors in the coalition and all of the members. We're usually in a program. It's the program staff that takes the lead in implementing the interventions. Next slide. So in CACA's work with coalitions and in the training that we do for the Drug-Free Communities program, we teach people to actually look at 7 specific behavior change strategies. The first 3 are what everybody tends to do, provide information to raise awareness about the costs, consequences, and issues with alcohol, tobacco, drugs in general, prescription drugs particularly, build skills in youth, peer refusal skills, social skills, etc., and also provide social support. But what makes coalitions different is they do strategies 1 to 3, but they spend a lot of their time on those outer levels and rims of the social ecological model, trying to change barriers and access for people to get the types of services and help that they need. Changing consequences, so making sure that if someone is selling to underage people, they're going to be fined, that there are consequences for the types of negative behavior that can create the issues in a community, and also incentivizing good behavior through rewards and recognition at a community level. Altering the physical design of the environment. You might have a park that has no lighting where it's a drug selling location, so the community could get together and actually make sure that it's lit, that there's enforcement there. Knocking down places that are known drug selling or using locations. So that's a very important component of this, and also working to change policies, practices, procedures, norms, and rules. We've done an amazing job in tobacco by enforcing the rules that people can't smoke inside of a building. So those are the types of things that we try to teach people. We need to do a combination of all 7 of these strategies across the whole community in order to get the biggest bang for the buck with reductions in substance use and abuse. Next slide. The Drug-Free Communities program is an ONDCP-funded program that has proven extraordinarily effective in reducing substance use and abuse rates in the communities that get funded. Next slide, please. So it is a federal grant program that supports community-based coalitions in preventing and reducing youth substance use. Since the beginning of the program in 1998, there's been about 2,000 coalitions that have been funded. Currently, there are about 700 grantees. The program has a very strong emphasis on environmental and policy change strategies, basically numbers 4 to 7 in what I showed you in those 7 behavior change strategies. And CADCA, the organization that I represent, is the primary training and technical assistance provider for the program, and we're extremely proud of our work in that area. Next slide, please. So coalitions have to do assessments. It's extremely important. So for every drug-free community grantee, there are core metrics for the program that actually must be collected and are then put into a national evaluation, and I'll show you that in the next slide. But let me just tell you, every DFC grantee needs to collect data on 30-day use, perception of harm, perception of parental disapproval of use, and perception of peer disapproval of use for alcohol, tobacco, marijuana, and prescription drugs for any 3 grades between 6th grade and 12th grade. That was a mouthful. But in addition to what's required that the coalitions collect for the national evaluation for drug-free communities, coalitions also look at local data that's extremely important to figure out what's happening in the community so that they can figure to their assessment, their planning, their implementation, and their evaluation. They look at emergency room data related to drug misuse issues, treatment admissions data, who's using what, at what age, when are they going into treatment, what are the issues, poison control data in places like Colorado with edibles for marijuana, what's happening with poison control and emergency room visits, arrest data, vehicular crash data related to driving under the influence of alcohol and driving under the influence of drugs, suspensions and expulsions from school related to drug misuse, high school graduation rates. So these coalitions are really looking from soup to nuts at the data in their community so that they have the fullest picture possible when they're going through that strategic prevention framework. Next slide, please. So the national evaluation from the Drug-Free Communities program has shown that over the life of the program, youth living in drug-free communities have experienced significant reductions in alcohol, tobacco, and marijuana use. It's actually greater than national averages from survey results from surveys like Monitoring the Future and the National Survey for Drug Use and Health for same age group of kids. Next slide, please. Not going to spend a lot of time on this slide, but this is actually the visual for the national evaluation for the Drug-Free Communities program. And as you can see, there have been significant decreases in both middle school and high school for alcohol, tobacco, and marijuana for all of the grantees that have ever been funded in the program. But the interesting thing on the right hand is that this is the 2013 grantees for the Drug-Free Communities program. It's the first time that prescription drugs were included in the national evaluation. And interestingly, so this was for 2013 grantees. So they were people who were funded between 2009 and 2013. These are 5-year grants. So you can see again for alcohol, tobacco, and marijuana, really, really good reductions. And actually the marijuana one's amazing because marijuana use over this period was basically not declining, and we've seen a 4.4 decline in marijuana use. But on the prescription drug use for the same period of time, among 12th graders, basically prescription drug use stayed at about 7%. And you can see for high school students in drug-free communities in this cohort, there was a 14.5% reduction in prescription drug use. That's an amazing outcome. And it's really a testament to the comprehensiveness and the data-driven nature of this program. Next slide. I'm going to very quickly take you through some local examples. Oh, I'm sorry, next slide. Thank you so much. Some local examples that actually mirror the types of evaluation findings from the national evaluation for the program. Next slide. The first one is Carter County in Kentucky. This is the epicenter of the prescription drug and heroin crisis in this country. And this is amazing. As you can see, among 10th graders in 2004, 9% of them were using prescription drugs non-medically every 30 days. That's way higher than national averages. And yet, because of the work of the coalition and because they were doing comprehensive strategies across multiple sectors, they were able to reduce from 2004 to 2012 prescription drug use among 10th graders to 1% from 9%. It's an 88.9% reduction. And they had about the same type of results for their 12th graders, an 83.3% reduction. It's really incredible results. Next slide, please. I'm just going to show you how important it is to understand your local conditions. So the source of narcotics among those who used them in the past year, this is from Monitoring the Future. Most kids actually get their prescription drugs from a friend or a relative. And so you have to understand community conditions. If that's how kids are accessing, you have to do strategies that actually address how kids are actually getting their hands on these drugs. To do strategies, say, for the internet, which is like almost nothing here, you'd have no effect because it's the wrong condition to be dealing with in this community. Next slide. I'm not going to spend very much time on the strategies that were actually implemented to achieve the reductions, other than to say all of these coalitions use a combination of the 7 behavior change strategies and work across multiple sectors of the community to make sure that messages, reducing access and availability, and changing social norms is done with enough scale and scope that you're able to actually achieve the types of population reductions I just shared. Next slide, please. These are underage drinking and marijuana results for a drug-free communities program. And the really amazing thing here is this is among high school students. Alcohol use was cut by 61.6%. Marijuana use was cut by 29.4%. And this is a community that also started with rates that were higher than national averages and actually brought them way down. Next slide, please. And I'm going to spend a minute on explaining this as well. So the way we just talked about how prescription drugs, you have to know how kids are accessing. For underage drinking, same thing. This is a community in California When they looked at how kids who drank alcohol were accessing it, they found out it was from house parties and family and friends. So again, you need to implement the types of programs, policies, and strategies that are going to affect how kids are getting alcohol. And if in this community you are going to do some sort of compliance checks in clubs and restaurants, that's not how kids are accessing. Therefore, those strategies probably wouldn't have been as effective. And on the right hand, you can see this community did have major reductions in underage drinking. Next slide, please. Actually, I'm not going to spend too much time on the next slide because, again, it's the strategies that were implemented to achieve the reductions. Next slide. I'm not going to spend very much time on this one either, but it's just another example of a coalition that started with really very high marijuana, alcohol, and cigarette usage rates. This is 8th graders, and they had 13% of them in 8th grade using marijuana every 30 days. That is really very high. And they got it down to 3%, which is around the norm for that grade level and that age. And again, it was, next slide, from doing multiple strategies across all of those 7 behavior change strategies that I outlined using multiple sectors of the community. Next slide, please. So the question of this whole webinar is, so why should hospitals and coalitions work together? And I think one of the reasons is that collaboration is critically important. If you're going to effectively address substance use and misuse issues that are in a community, it's important that the data that's collected and analyzed by the coalition be considered for inclusion in the community health needs assessment that the nonprofit hospitals are required to do. Because if we want to improve community health status, getting on top of alcohol, tobacco, illegal drug and prescription drug issues is critically important because we've found that where the data is brought to the community hospitals, usually it ranks pretty high up. And I want to just give you 2 incredibly great examples of where coalitions and nonprofit hospitals have actually worked together to change the environment and the climate and actually outcomes in communities. The first one, next slide please, is Drug-Free Muskegon County in Michigan. In fact, Mercy Health was the lead agency for this particular coalition. Oh, sorry. Are we missing some slides? Oh, you know what? Never mind. Go back. These aren't slides. I was going to speak to these. Sorry. So I'm going to go through my examples without slides. Sorry about that. So in Drug-Free Muskegon in Michigan, the coalition actually convened a community focus group to find out what were the sources of prescription drug diversion. And what they found out was that the hospital itself, and this coalition is, housed in the community benefit office of the hospital, it was the hospital's own prescribing practices that were causing some of these issues. So the hospital went back and changed its prescribing practices based on the coalition's community convening and what they found, which is a very interesting collaborative approach and an interesting outcome from that. And the Tennessee example is extraordinarily interesting. The Allies for Substance Abuse Prevention of Anderson County had their hospital from the very beginning of the coalition's formation as one of the major players, actors, and sectors. And when they looked at all of their data for the community health needs assessment, not only was the prevalence of youth substance use and just substance use in the community in general a problem, but the prevalence of neonatal abstinence syndrome was astronomical. It was horrible. And so, in fact, the coalition working with the hospital brought together everyone in the community that could help figure out why neonatal abstinence problem was such a problem, and then also the hospital was having a really large problem in the prevalence of readmissions as the babies were sent home from the hospital who were being detoxed because they were being sent home with methadone. And unfortunately, they were being readmitted because the parents of these children were actually using the methadone. So the community coalition and the hospital working together changed the prescribing practices and how these babies were treated in the hospital so that they were sent home not on methadone, so that they were already totally detoxed when they were released from the hospital. In addition, through a gigantic analysis that the coalition did with the hospital so changed its prescribing practices from sending the kids home on methadone to using morphine so that they were totally detoxed. The other thing the hospital and the community coalition did together, because of the really epic proportions of the amount of neonatal abstinence syndrome babies that were presenting, they did a logic model analysis and figured out they needed to do a large educational campaign and a media campaign around neonatal abstinence syndrome. And in fact, the hospital's been an amazing partner with the coalition in a large regional effort to prevent neonatal abstinence syndrome. And they have ads that have been in bus stations, that are on television, and basically they say when it comes to any drug, the best mothers ask questions. Should I be using this? Is it safe for my baby? And your baby's life shouldn't begin with detox. So they've seen reductions in this issue since they have changed their prescribing practices to treat the babies and in doing this large media campaign. So some next steps, I think for hospitals who are on the phone, seek out the coalition in your area. Get involved and invite them to provide input into the community health needs assessment and implementation plan, because they have done a tremendous amount of data analysis, strategic planning, and multi-sector implementation. Hospitals are a wonderful, wonderful partner. And coalitions can bring the data and understanding of the local conditions, environment issues, and a lot of the assets the communities have to bear on what the hospital is doing. And for coalitions, people who have been really successful have sought out their local nonprofit hospitals at the very beginning of getting involved in building the coalition so that they can identify areas of mutual concern, work together in task forces and collaboratives with the hospitals to solve problems that it actually takes the hospital involvement to solve, and to share information about your coalition, its members, your data, etc., so that you can actually get your information and data included in the needs assessments. And that would be the wrap-up of my portion. I think we're really on time here.
Very well done.
Thank you.
So thank you for that excellent presentation and also for the real-life example.
Welcome.
Thank you. For our third and final segment, I will turn it over to Leslie Aldrich, who will talk about a very unique model of hospital and community collaboration.
Hello, everybody. Thank you for listening today, and thank you all for giving me the opportunity to present. Next slide, please. So I'm here to kind of give you that real-world example sitting here at the hospital. I'm here today to tell you a little bit about our Center for Community Health Improvement, which started at the Community Benefit Office, how we partner with communities, the value of this partnership, and how we've leveraged our assessment process to influence Mass General's strategic plan. Next slide, please. So first, just to put this into context for you, I'll tell you a little bit about our hospital and who we are, for those that don't know. We are the oldest Harvard teaching hospital. We were founded in 1811, so we're pretty old. We have 1,000 patient beds and serve 1.7 million outpatients annually. We're one of the largest employers in Massachusetts with over 26,000 employees. And we're not only known for our patient care, but for the research that we conduct here at the hospital. And I'm also happy to report that we're now also known nationally for our community work. We're the recent winners of the AHA's Foster McGaugh Award for Community Service. So our community commitment runs deep. We have 3 community health centers that have been operating for close to 40 years. These health centers are significant partners in our work. Next slide, please. The health centers were founded, next slide, please, were founded to increase access to care for our most vulnerable populations and are therefore located in our most diverse socioeconomic and ethnically diverse communities in and outside of Boston, as you can see here in this slide. These communities are Revere, Chelsea, and Charlestown, which is a neighborhood of Boston. And these communities are not only where our health centers sit, but also where we as a center do most of our work. Both Revere and Chelsea are very diverse communities. They have very low graduation rates. In Chelsea, over 60% of the residents are Latino. And in Charlestown, being a neighborhood of Boston, it has one of the highest per capita incomes of any neighborhood in Boston, but it also has among the highest child poverty rates in the city. So we really need to do a lot of work there. Next slide, please. So to tell you briefly about our center, we're in essence the public health arm to the hospital. We were founded in 1995 to carry out the community benefit mission of the hospital, and we started out as one person. And when Joan Quinlan, who is the Vice President of Community Health now, when she first started this 20 years ago, she conducted health assessments to help determine what priorities to address and strategies to use, and we have done this consistently since the beginning. One of our first responses to a community assessment was forming a multi-sector coalition. It was our Revere Cares Coalition. I'll tell you a little bit about that. And we were fortunate to receive drug-free communities once we started that coalition. And that really brought rigor to the model. It gave us data and the evaluation and technical assistance we needed to really make that a robust coalition. This coalition still acts today, and I'll have to say this strategy of setting up coalitions to address community needs truly shaped the way we have worked and how we respond and work with communities, and how it's actually shaped how the hospital runs, which I'll tell you a little bit about. So fast forward 10 years, we built a strong body of work since then in all our communities. We realized we needed to create more internal awareness. Thus, in 2007, we changed our name to better represent the work that we do with the hospital. And we changed the mission statement of the hospital to include the community health. Today, after 20 years, we support over 31 initiatives in and outside of Boston to improve community health, and hospital leadership is invested in this work. We have both a board committee on community health and executive committee on community health comprised of hospital leaders. Next slide, please. So just quickly, our approach to community health is really guided by the health impact pyramid developed by the director of the CDC, Tom Frieden. The pyramid illustrates kind of, the social environmental change that needs to happen. And as you focus really on these policies and systems change at the bottom level, it enables you to have an impact on the largest number of people. And as you go deeper and up the triangle here, you have an impact on a smaller number of people. But implementing interventions at all levels, you achieve the maximum public health benefit. Next slide, please. So at the center, we call ourselves CCHI. We focus our efforts in 3 areas that follow this health impact pyramid. At the top of the pyramid, we work with vulnerable community members and patients to increase access to care through community health workers and navigators. In the middle of the pyramid, we work to improve opportunities for young people through STEM education, science, technology, engineering, and math initiatives. And through this strategy, we work with really over 650 youth yearly. And today, we have 4 now multi-sector coalitions that I'll tell you a little bit more about, all working on prevention of substance use disorders, in addition to promoting healthy eating and active living. And so our coalitions have really morphed to be healthy community coalitions. Approximately 25% of our expenditures at the center are allocated to this coalition strategy. Next slide, please. So as you know, and everybody has said on the phone, we know that we can't do this work alone. That's why we created these coalitions. So we use this collective impact approach not only in our coalition work, but in all the other strategies and interventions we implement. And this approach was published called Collective Impact in the Stanford Social Innovation Review. And as you see, it says when organizations from different sectors agree to solve social problems using a common agenda, large social impact is possible. And what this really says here, and it shows you, is that this backbone support is what's really important to help sustain this work as well. Next slide, please. So to go a little bit more into this backbone function, at CCHI, we provide the backbone support to these community coalitions. That's how we like to call it. And what this means is we don't simply act as a funder or just lend our voice, but instead we really pursue these 6 common and shared functions to support and facilitate this collective impact in communities. We help guide the coalition's vision and strategy. We support aligned activities. We establish shared measurement practices. We build public will through continuous communication. We help advance policy and advocate, and we help to mobilize funding so these coalitions can sustain and have a larger impact. To be more, next slide please. To be more concrete, I'll tell you just a little bit about how this backbone organization looks like. I'll share with you some specifics about how one of our DFC coalitions is structured and kind of my perspective on the benefits of a hospital being involved in this way. I'll tell you about our Charlestown Substance Abuse Coalition, which formed in 2003. As you can see here, in 2003, rates of substance use-related hospitalizations and drug-related deaths among Charlestown residents were 50% higher than Boston overall. It was soon after this data came out and a tragedy occurred that community asked Mass General Hospital for help. And at this time, we lent our experience to convening communities, and the MGHCCHI's director at the time facilitated community meetings with 50, 70, 75 people for really a full year. After a year of really kind of establishing this base group and coalition, we finally hired a coalition director with hospital funds to help sustain that work being done. And soon after, this coalition received Drug-Free Communities grant money, which they still hold today. Next slide, please. Since 2004, Charlestown has grown in size as far as staff. Each coalition is structured differently, but I'm just telling you about Charlestown here. This slide gives you an example of how this work progressed. As you can see, the hospital still pays for the coalition's director position as the main staff person to the community coalition. But through grant dollars from both Drug-Free Communities and additional dollars from the hospital through determination of need money, a total of 3 more positions have been created to help respond to the needs of the community. Today, with a total of 4 staff and over 75 volunteers, this coalition is broken up into 5 task forces that directly work on the issues identified by the community. Next slide, please. The coalition works on both primary prevention, secondary prevention, or we can say, as Bethany has taught us, universal, selective, indicated, peer interventions. And it works, as you can see here, in many different ways. The coalition partners with youth-serving agencies to deliver evidence-based curriculum, works with large youth groups who develop positive social marketing campaigns. And today, unfortunately, a lot of our time is spent working on the opioid epidemic, conducting activities to help get people the help they need, especially when they're in a crisis. Next slide, please. How the hospital gets involved outside of our community benefit department as well, and who are on the ground doing this work. We as an organization offer our expertise to help deliver social marketing campaigns. We have a communications person who helps with that. We recruit staff, particularly physicians and pharmacists at the hospital, to be involved in community interventions such as take-back days. We help collect and analyze data and advocate for other funding to support the coalition. We have evaluation staff here at the center that help our coalitions collect this data. And in addition, hospital leaders work side by side with coalition members to advocate for policy changes. And there's many examples where we'll be at the State House coalition staff, volunteers, and physicians, center-wide staff, where we're all kind of advocating for certain laws and policies. Next slide, please. So is this model successful? I think we've heard some examples already from Sue. This is really some long-term progress data from our Revere Cares Coalition that you can see here really shows the decline in alcohol, specifically underage use. And Revere substance use indicators used to be way above the state average and national average when we started this work close to 20 years ago. Today, they are below the state average and have declined at a faster rate than other communities in the state. So we're very happy about that. Next slide, please. When we look at other communities with past 30-day use, you can see this decline as well. But what you can see here in Chelsea, this red line, there seems to be an incline. As a result, because of this data and finding from our 2012 Community Health Needs Assessment, we've started a new coalition to prevent and reduce substance use and are in the early stages of working on this issue. And you can see these dots here are kind of the goals we have set in place for this particular indicator. Next slide, please. In addition to alcohol, we're concerned with youth marijuana use. Up until 2009, rates have been fairly low in our communities, but as a result of some new state laws decriminalizing marijuana and recent legislation to make medical marijuana legal, we're seeing inclines in use. Again, we're hoping to combat this in all communities through our coalition model. Next slide, please. And this slide really just shows you what we're up against right now. And it's really a lot of this work in all of our communities is focused on this opioid epidemic. It's an issue that truly cannot be tackled by one agency, organization, or hospital. It really needs to be done by having everybody be involved. Next slide, please. So the benefits to this coalition hospital partnership. I'm fortunate to work for a hospital that really believes in prevention and engaging with communities at a grassroots level. The benefits to this model, I think, are great. Not only is it community work strengthened as a result, the hospital benefits tremendously by having staff on the ground to provide community connections. It gives us information and help us assess the needs of the communities, which we now know is a requirement. Next slide, please. So our community health needs assessment work has really helped coalitions develop and redevelop over the years. But most recently, our community health needs assessments and the coalition work that we've been doing has also influenced how the hospital delivers care. So I'll tell you a little bit about that now. Next slide, please. Although we've been actively assessing communities since we started this work in 2012, we used the new Affordable Care Requirement as a way to improve upon our past assessment processes and thus use a new framework to assess all of our communities at once. So since 2012, we've talked to close to 4,000 individuals to find out what people believe are the leading health concerns. And not surprising, substance use, particularly opioid usage, and public safety, along with crime and violence, remain the top two perceived health issues for our communities. And unfortunately, and I didn't include the data, this data is not just perception, but it's supported by the rates of opioid use and deaths within the Commonwealth, along with some violence indicators. Next slide, please. So what did we do with this? So in 2012, the stars really aligned for us here at Mass General. Right after we finished our community health needs assessments, we at the center were asked for the first time in Mass General's history to develop a strategic plan for the hospital around community health, similar to the other mission areas of the hospital. And we did this by working with others across the institution to explicitly connect community health to our other missions. So because we were in the mission statement of the hospital, we were invited to the table for the overall hospital strategic plan. So this is huge for us. Next slide, please. So what did we do? We brought our community health needs assessment findings to population health management, which prompted them to look at patients diagnosed with substance use disorders. We said substance use is the leading health concern. And we also brought other data with us to the table as well, data around obesity, data around violence. But population health management really looked at the data for patients around substance use. Next slide, please. And as you can see, not surprising at all, we could have told them this years ago, but as you can see here in red, readmission rates for certain diseases are higher for those with a substance use disorder. I think we probably all would know that. Both pneumonia, COPD, and heart failure, and those are, you can see, higher in red here. Next slide, please. And not surprising, there's a high prevalence and cost. 29% of Mass General's high-risk patients had a substance use disorder, and those that did were more costly and had higher readmission rates. Next slide, please. So this data was then used to develop a hospital response to improve the care for patients with a substance use disorder. After a year of early meetings, a comprehensive new initiative that spans from both the bedside to the community was designed and submitted to the hospital leadership, along with all the other kind of proposals that were put in. And after careful review, hospital leadership made it the #1 clinical priority of the entire hospital strategic plan. We're pretty proud of that. It's the first time we were aware that a community needs assessment really drove the major clinical priorities of an academic medical center strategic plan. And this is not anything I really thought that I would see in my lifetime here. I've been doing this work for over 16 years now, so it's quite exciting. So this, of course, could not have been done without committed individuals and committed and passionate leaders at the hospital. Next slide, please. So in brief, this initiative really consists of a consult team that meets with patients at their bedside, enhanced care at our health centers, more access to medication-assisted treatment, and greater linkages with community-based providers through recovery coaches. These recovery coaches are peers in recovery that help guide patients through the process from the hospital to the community, and they work with patients wherever they are on the spectrum of readiness, even if the patient is not ready to quit. And these recovery coaches also are sitting in our coalitions as well and helping provide data on what's going on the ground level and really what's happening and the barriers to care. So as a coalition, we can be working on those together. Next slide, please. The data is still being reviewed after a year, but after a year of being in this, we have some findings. Preliminary findings have revealed both early successes and the challenges we still face. The patients we are seeing are both medically and psychosocially complex. However, in spite of these complexities, we've seen impressive successes already. Comparing the patients we've seen this year to the subset of patients who are also admitted to the hospital last year, we've already reduced the length of time they've spent in the hospital by nearly a day. We have similarly reduced utilization of the emergency room in that group from 58% to 24%. And additionally, patients are reporting a 67% increase in the number of days they have remained abstinent. Next slide, please. Additionally, patients who once felt ostracized now feel like they are being treated with dignity and compassion, and we've heard this over and over. Substance use disorders, once referred to as substance abuse at this hospital, is now thought of as a chronic disease, which is truly monumental. Next slide, please. So what have we learned? We've learned a lot. It's been a really fun and interesting journey. It's one that takes a lot of time and effort and persistence. As far as substance use, our community health needs assessment really revealed that substance use is an increasing concern to our communities, that addressing this issue is not work a hospital can do alone, that really our coalition model is really a truly effective model. Without those coalitions, getting at this community-level data wouldn't have been possible, and having that voice of the community and bringing that and combining it with the patient-level data and bringing that to the hospital really formed a strong proposal and a loud voice. And then, so just aligning these two data sources and the community voice and then the hospital's kind of patient voice, we were able to make change and the largest health impact. Next slide, please. And I think we've went through this already, and I think Sue shared, you know, if coalitions are on the phone, how do you get started? Identify kind of your local nonprofit hospital. Building relationships is the key to all of this. Find out where hospitals are in their assessment process. See if you can be involved in that process. Next slide, please. And how hospitals can get started. Again, it's all about relationship building. If you don't have the capacity, we're fortunate here at Mass General to have more capacity than most. We realize that. But one of the reasons we have such large capacity now is because we have such big staff. We have so many people on the ground in our communities that are helping do this work, and we do this together. So really it's about creating and finding community health champions, both internally in your organization and externally out in the community through coalitions. Join a multi-sector coalition, form that partnership, build the trust. It takes time. If you're not going to be a backbone organization like we are really on the ground creating these coalitions, being there as an active member is key, and building the trust so they know why you're there and what benefits they can have by you being there and how you can benefit by being part of this group. The community and hospital assessment process, again, hospitals can measure for substance use and risk and protective factors in your community health needs assessment, not just about the patients. Measure policies and practice in the hospital that promote health, equity, and safety. So really make this a larger, collect the most data you can. Analyze this data and review it with hospital leadership. and then match these evidence-based interventions we've all heard about through Bethany, Sue, to the community health needs assessment and form that plan. And then, of course, align the hospital priorities with your community priorities when possible. Next slide, please. So I think that's it. This really just ends with a summary just showing you how rewarding this really has been for us as a hospital. And this is just strategically now we try to address the issues as they arise for both primary community-based prevention to early intervention and treatment to chronic disease management. And as we are working in the community, we're now working to transform care. Next slide, please. So thank you very much. If anybody ever has any questions, please feel free to email me or call. I'm happy to take any questions. Thank you all very much.
Leslie, thank you very much for sharing the work of your hospital and the community and for your remarkable successes. May they continue.
Thank you.
Thank you to all of our presenters for their very informative presentations, and we will now begin the Q&A session. Operator, could you please open the lines?
All right, and to our audience members, if you would like to ask a question, you may dial #2 on your telephone keypad, and this will place you in the question queue. You will hear a notification when your line is unmuted. At that point, please then state your name and question. And as we wait for audience members to queue up, I believe we're going to go ahead and read some of the pre-registration questions.
Right. We had some questions coming in during registration, so we'll start with those. First question. A coalition is being formed in our area, and the group does not want to have anything to do with the community health needs assessment or the hospital. Why should we work together? And I will turn that over. Leslie, do you want to start, and then we'll go to Sue?
Sure, and I think I touched on this a little bit. I think the key there, if a coalition is at all resistant, really kind of building that trust and partnership with them. And because community health needs assessment is required, working with a coalition just for that purpose may be seen as kind of a heavy ask and only for the benefit of the hospital. So going in as a hospital and really being part of that coalition for a while, maybe the coalition won't help with that first community health needs assessment, but maybe in a couple of years they will after they see the value of that partnership.
Thank you, Leslie. Sue, did you have anything to add?
Yeah, just that it truly is a win-win, and if you ever want to get to the point where you can work with the hospital on a joint initiative that perhaps the hospital could help to fund, you have to actually be in the community health needs assessment and have your issue ranked. So it can be a win-win, and it's a big mistake to not understand the bigger picture. And just really quickly, I think the coalition has skills, competencies, and knowledge that the hospitals really can use. Leslie did a brilliant job of pointing that out. But the hospitals actually also have skills, knowledge, and competencies that it would be very important for the community to be involved with. And I think the Tennessee example for the neonatal abstinence syndrome is a really important one. It was a gigantic epidemic in that part of Tennessee, and they've actually really worked together to have major impacts on something that was really out of control in their area.
Thank you, Sue. And Leslie. We have another question come in. How can the community benefit help people being released from the criminal justice system? Leslie, would you mind taking that one?
Sure. So I think it's really kind of making the case as to why and how this could help. I think our community health workers, navigators, are great to work with the population. We do have a community health worker who we fund through community benefits and also through determination of need dollars that work in their drug court right now. So they're not post-incarceration, but pre-incarceration really, and hopefully not be incarcerated for this. To work and really navigate people to make sure that they're receiving treatment and the benefits that they do need. Another way to do this, at Mass General, we do have what we call called the Crimson Care Collaborative, and it's both Harvard Medical School students who form a collaborative with faculty here at Mass General, and they really develop a collaborative practice, and they've formed a clinic at it's called the Nashua Street Jail right now, and they operate that a couple days a month, I believe, really working with inmates to transition them, back really to community. So that is a model, something that community benefit dollars could fund.
Thank you. That's really helpful.
Mm-hmm.
And we'll take one more question from the pre-registration, and then we'll go to the online. And this is definitely for Bethany. Where is a good online source for evidence-based prevention programs?
Sure, happy to answer that one. I'd refer you to the last sets of my slides. I have the URL links to make it easy for you all. So I spent some time going through a sampling of the content that's in our guides that NIDA has produced, so that those are several resources for you there. And then as well, I would encourage you to go to SAMHSA's National Registry of Evidence-Based Programs and Practices. And also, I think Blueprints would probably be a good one, too, to start with. So those would be a good slate to begin to get your feet wet, to see the universe that's available to you.
Bethany, thank you very much. To our operator, do we have any questions that have come in?
And we do have one question from the audience, and let's go to the line of Tammy Nicholson.
Okay, Tammy, please go ahead.
Yes. Good afternoon. This has been wonderful. Will the PowerPoint be available?
Yes. It'll be posted on our website, and I'll talk about that a little bit more at the very end.
Okay, thank you.
You're welcome. Do we have any other further questions?
We have no further questions in the queue, but as a reminder to our audience, dialing #2 on your phone will place you in the question queue.
Well, while we're waiting for another question, there was another one that came in, and maybe this is for everyone, which was if you had to give a recommendation, one sort of top 2 things to do for a hospital and top 2 things to do for a coalition, wanting to get involved in this area, what would you do? I know we've touched on it in some of the in the presentations, but if you could summarize the top 2, I think for everybody. Sue, do you want to start?
Sure. Well, the top 2 things for the coalition would be find out who the people at the community hospital are. It can be doctors, it could be someone in the community benefit office that you could approach to actually get involved early in your coalition. And then really work with them as you're doing your needs assessment part of your strategic prevention framework to see if you can then share what you've come up with to try to get it to be included in the community assessment that the hospitals are required to do. So my thing is think of win-win from the beginning. You both need data, and the data is from the same community, and it can really be used really wisely by both parties. So that would be my take.
Perfect. Thank you. Bethany, do you want to?
Sure. I think my 2 would be, the first one is that since we're all about fitting different puzzle pieces together, to always have in the front of your mind about finding common interests as everybody gathers to the table. There's a lot of power when you can center on that as quickly as possible. The other thing from a researcher point of view, I wanted to let you know that there are many fantastic prevention researchers scattered across the United States. We fund 192 of them right now this very instant at NIDA. I've shared a link on how to find them in your local backyard. There are wonderful people to be included in this process, and would encourage you to do so.
Thank you. Leslie, you have 2?
2. I think 2, use your data, and I completely agree with both Bethany and Sue, and finding those common issues and the alignment, really showing how you can add value by bringing something to the table is key. Really being active in the community. If you're low on staff, to be active and being involved, to really find those community health champions within your institution to be active for you and then report back and to deliver your message. And use the resources that Bethany has brilliantly described, because it really helps to bring those to the table and not reinvent the wheel. So, yes. my recommendation.
Thank you very much. From our operator, do we have any questions in the queue?
Yes, we do. Let's go to our first caller, Rashmi Shenvi.
Rosh, please go ahead.
Yes, hi. Thank you so much. So I wanted to ask, what kind of advice would you give for communities that have a for-profit hospital whereby they are not mandated to do a community health needs assessment?
That is a great question. Leslie, would you be willing to take that one?
Yes, I can. I mean, if they're not required, I would bet they're still very interested in it for their own purposes. So it's really finding the right people at the hospital to have some meetings with to talk about the benefits of collaborating, really. The health needs assessment, we have a lot of nonprofit hospitals, or profit hospitals in the area who also sit at the table, and they're vested in the process. So it's really just getting and finding the right person to meet with.
Sue, did you
Yeah,
have anything?
I was going to say back to the win-win, I think Leslie did a brilliant job showing that readmission rates go down, that in fact, you have less issues in the community when you have less substance use abuse and addiction. So therefore, I think any hospital would be interested because it's a cost-saving thing to prevent it, but also to intervene early and to treat it and to make sure there are recovery coaches in the community so people don't relapse.
Exactly. Yep.
I think we have time for one more question. Operator, is there anybody in the queue?
We do. We have another audience member. Let's go to the line of Nancy Schumacher.
Hi, Nancy. Please go ahead.
Hi. I was just wondering what you think of the effectiveness of a program such as DARE has with this kind of program.
Bethany.
Yeah. Bethany, would you like to?
Well, I actually wanted to parallel some comments that Sue had mentioned before in her presentation, that I'd like to get away from talking about specific programs and move to how the programs come together to solve community needs.
Right.
And so I really think that part of the power, I think, of having all of us speak together in this panel was showing how the evidence can come together to solve specific needs in the community. And in that community, is it, are there, high risk factors that need to be addressed? Do you need family? Do you need to bolster family prevention interventions? Do you need to focus on availability of drugs? And so it's these kinds of specific factors that I think should drive the selection of programs nested in what the coalition and hospitals come together. So I think it's more of a broader comment.
Right. And I think, too, as far as the DARE program, I think it's been shown that the scare tactics that go along with that have not been shown to be truly effective. Bethany, you may know more, but again, it's about increasing those, protective factors and decreasing the risk factors, not so much about the message that program gives.
And I just want to say nothing about DARE at all, but just programs are necessary but not sufficient, and I think that's the point Bethany was making,
right.
That just picking programs off a shelf because it looks like they're evidence-based, if they don't meet the actual needs in your community as identified in your community assessment, won't probably work to move the needle. So you have to be really careful that you pick things that actually meet the needs that have been identified in your community.
Yeah, and I also just wanted to end with, I think, what was peppered through a lot of the presentations today was that this cohesiveness together of having these puzzle pieces come together is really important to make population-level impacts.
Thank you, everyone, for your answers, and thank you for the questions. We'll wrap up now. I really would like to thank everyone for being here today. I mean, substance use impacts every community and ultimately impacts the nation's health. We want to use all tools available to address this issue. And I think the community benefit and its role in bringing together nonprofit hospitals and community members could never be more important. So next slide. Just want to leave you with a few resources. We urge everyone on the webinar today to reach out to community partners and join forces. I'd also like to encourage everyone to take advantage of resources on the ONDCP website here. We now have a community benefit web page where you can find general information, a printable fact sheet, slides and video from our first community benefit webinar and shortly this webinar. The Drug-Free Community site has information about the program, where to find current grantees and how to apply. There's also a directory of current drug-free community support programs and also HIDA grantees. Almost all high-intensity drug trafficking area grantees work with community-based coalitions to support prevention. And finally, you can learn more about research and data sources beyond the fabulous information Bethany has provided. And next slide, please. We just want to say thank you for being here today again, and that's all the time we have. Unfortunately, if you have questions, my contact information is there at the bottom. And have a good afternoon, and thank you for joining us.